Hi, my name is Paula Blackstein-Hirsch, and this webinar is about how organizations define quality. For many boards, one of the first topics of conversation regarding the quality agenda is, how is quality defined? Some organizations, in fact, can spend months debating this definition and never actually getting to doing anything. This slide includes a number of possible dimensions for defining the concept of quality. These come from a variety of sources, including the Institute of Medicine in the United States, Health Quality Ontario, the Excellent Care for All Act, and a number of quality councils across the country. On the next slide are listed several groupings of dimensions. Take a moment and reflect on these, and using the slides that you likely downloaded from the OCSA website, circle the grouping or the number that you believe reflects the 5 dimensions of quality that are incorporated in the Excellent Care for All Act. Okay, as you can see on this slide, the second option is the right one, the one that includes safe, effective, accessible, integrated, and client-centered, the 5 dimensions of quality included in ECFA. My suggestion to most boards in Ontario is to adopt these 5 dimensions. There are few, if any, quality issues that would not fit within these 5 dimensions. Additionally, since quality improvement plans are likely to be required by CSS agencies sometime in the future, to prevent having to report differently internally versus externally, my suggestion is to adopt these 5 dimensions for now. It's possible that sometime in the future, either the Ministry or Health Quality Ontario may add a 6th dimension focused on value or cost. This next slide reflects 2 different types of scorecard, one being a typical corporate scorecard fashioned after Kaplan and Norton 4 quadrants, and the other a quality scorecard that incorporates the 5 dimensions of quality that we've just looked at. You can see that 4 of the 5 quality dimensions align with the internal process quadrant of a corporate scorecard. The person-centered dimension aligns directly with the customer satisfaction quadrant. If you don't have a scorecard and you're just starting out, you might want to create a quality scorecard using the 5 quality dimensions included in Health Quality Ontario's template for quality plans. If, however, you've been using a corporate scorecard and intend to monitor only one scorecard in your organization, I would insert quality indicators into the internal process and customer satisfaction quadrants of your existing scorecard. Finally, if you have a quality committee and you have a corporate scorecard already reviewed by your board, you might want to develop a separate quality scorecard for detailed review by your board quality committee that's aligned with your quality plan. I'm often asked what types of indicators might fit into these 5 dimensions of quality. This is not a list that's being developed by an official organization of common indicators for the CSS sector. Indeed, OCSA is in the midst of discussions with Health Quality Ontario to partner together and consult with the field on a common set of indicators that might be used by the sector in the future. So let's take a look at some of the potential indicators that can fall within each of these 5 dimensions. The safe dimension is fairly simple, including any type of adverse or critical events that might occur within your organization, such as falls, pressure ulcers, medication errors, etc. Alternatively, you might want to link indicators within this dimension to required organizational practices required for accreditation. Some organizations include staff injury in this dimension, although the 5 dimensions of quality really are intended to include only client-facing indicators. The next column, effective, can include a variety of indicators. The examples here are percentage of clients with high or very high MAPLE scores supported by CSS in the community. So essentially, being able to support clients who have complex conditions in the community, preventing them from having to go, for example, to long-term care. Could also be around improving or maintaining functional capability, helping clients to meet all of their goals, or ensuring that services are received within a certain number of days of admission, although that latter indicator might sort of fall within an access domain as well. Moving then to the accessible domain, really any type of indicator that counts days from one point to another point that reflect wait lists, number of days from referral to receiving treatment, number of days from referral to receiving assessment, etc., service denials, number of people on a waiting list. It's really about wait time for service, access to service. The next column, client experience, can be anything generally taken from a standardized client satisfaction or client experience type of survey. It can be at a high level, like the number or the percentage of clients who might recommend your service to others, or it can be more detailed, focus on a particular issue like provider continuity or difficulty in accessing service, but the client perspective on that, or anything else that comes from this type of survey. It can also include number of complaints. Finally, the last indicator includes indicators that reflect integration of service delivery. And so any indicator that you wouldn't want your organization being held solely accountable for is the kind of indicator that should fall within this column. So things like clients who end up having unplanned hospitalizations or repeat emergency department visits, because it isn't only the role of CSS sectors to contribute to these kinds of outcomes, it's also up to other organizations in other sectors to combine or partner with CSS agencies and collectively to impact these kinds of metrics. Some organizations will place some of these kinds of metrics in this final column into effective, with the rationale being that if you can keep people out of emergency departments or out of hospital, then you're being effective in your service delivery. So they could really fit under either of the two domains. The challenge is that if these kinds of indicators get put under effective and you want a balanced set of indicators, there's nothing really left to put into this final column. If I were a CSS agency and trying to develop a scorecard, what I would suggest is to first look through the kinds of indicators that you're currently collecting and try to align them with these 5 domains. And then reflect back on this question: how would I know? How would I know that my service is safe? How would I know that my service is effective? How would I know that my service is accessible, etc., to help to brainstorm some indicators that might align with these dimensions of quality for your organization. So let's take a look at some indicators and provide you with the opportunity to determine which quality dimension you would place the indicator into. So taking a look at this first one, number of falls with injury. Look at the 5 dimensions and think about which one you would put it into. Looking at the next slide, you can see that that indicator falls within the safe dimension. Let's take a look at the next one, percent clients with repeat emergency department visits. Which domain would you place that one in? That falls within the final column, integrated, recalling that we just talked about the fact that CSS agencies can't impact that solely. It requires partnership with other organizations. The next one is percent clients with stable or improved functional ability. Which domain would you place that one in? So that one falls within the effectiveness domain because that really is one of the key reasons that CSS organizations exist, to maintain or improve the level of independence of clients, hopefully to remain in the community. The next one, number of days between medication errors. And that one falls within the safe dimension. And what I'd like to just point out in terms of that indicator is the framing of that indicator, number of days between critical incidents, is often a good way to measure rare events. If you were graphing it and you just looked at the number of medication errors, you'd get a graph that looked like a bunch of spikes, because hopefully you'd have a lot of zeros. So by doing it this way, you measure the time between and you don't get that kind of a graphic depiction. Let's move to the next one, the number of client complaints about wait times. This one's a little bit tricky, so think about it carefully. Okay, so moving to the next slide, we see that that falls into client experience. You might have thought that that could go under the accessible domain, but the focus of that indicator is on client complaints that happen to be about wait times. They could be complaints about a variety of things, but the focus for that indicator is the client's perspective on service delivery articulated through a complaint. The next one, average number of days from assessment to service initiation. That one falls under the accessible domain because it's about a wait time. How long from assessment to service initiation? So that's the end of this webinar. And just to summarize, what have we covered? We've talked about how we define quality. In Ontario, my suggestion is that organizations ought to align with the 5 dimensions included within the Excellent Care for All Act. Those 5 dimensions are safe, effective, accessible, client-centered, and integrated. And then, depending on the type of service you deliver, there are a variety of indicators that can be monitored within each of the 5 quality dimensions. These should be outcome measures and should answer the question, how would we know our service delivery is accessible, effective, etc. Good luck as you now go to think about how you'd like to define quality within your organization, and think about setting up a scorecard and identifying indicators that will fall within these 5 dimensions of quality.